I like to say our office does really four things within ONC. The first is that we bring together stakeholders who have a problem that they're trying to solve, and then we provide shared solutions for them. And so we use something called the Standards and Interoperability Framework to bring together different constituents, have them agree on a particular solution, and then create standards around that support interoperability. The second thing that we do is, as we grow this portfolio of different solutions that have been developed in those communities, we manage that portfolio by making sure that we update it if we recognize that there are problems, and to support implementation and the testing that goes on before these technologies might get certified. The third thing that we do is that we engage with the innovation and the science community so that we can keep the pipeline of innovation that we need to drive a lot of the standards work, and that we can always be fresh in terms of our approaches and more forward-leaning, if you will, in terms of what we do. And the fourth thing that my office does is that we work across our federal agencies through the federal health architecture to make sure that the various federal agencies that deal with health information both can support the kinds of standards that we adopt, but also their interests and their needs are heard in this national conversation, because they'll be such a pivotal part of being able to make sure that we've got that ecosystem out there to support interoperable healthcare systems. So I don't think we are necessarily at the place we'd like to be when it comes to usability. We need to do some additional work, I think, to improve that. And we need to take a variety of different approaches to doing that. We need to try to emphasize the importance of sort of user-centered design, and that was one of the pieces that shows up in the Meaningful Use Stage 2 certification criteria, is to have some sense about how people are developing the systems that they're using. I also think it's important that we have ways that we can share best practices. And we need to have also ways that if a provider buys a system that is not as well suited to the way in which they practice medicine as perhaps another system, or if there's a new system that comes out, being able to move information from one system to another, I think is going to be helpful to improve usability and to empower patients, and to empower providers to buy the system that's the best suited to the way in which they practice medicine. So I think as we get things to be electronic, we are going to see some changes that will occur, both in terms of the functionality that the electronic health records provide, but also if physicians have made choices that they later would like to update or move to a new system, we have to provide mechanisms for those things to occur. We're spending a lot of time and energy within the Meaningful Use program to create ways to capture data in more structured and standardized ways. And the reason that that's important is that if you want to be able to, say, graph a patient's blood pressure over the course of time, or if you wanted to be able to calculate what their average blood sugar level was, or to create some notion of how well your practice is doing, potentially, on its ability to manage obesity or cardiovascular disease, or even our ability to sort of understand what's going on at a population level with regard to cardiovascular disease or obesity or other things like that. Capturing information in a structured way makes it simpler to do those calculations. And I think there will always be a role for that, but I think we have to be tremendously sensitive to the burden that capturing structured data has on the physician and the providers that are using that information. So we have to approach that with a certain degree of parsimony. We have to make sure that just because we can structure it doesn't mean we should. And I think we gain a great deal of value in the narrative that also occurs in the interaction between a doctor and a patient. Because healthcare is really, when it comes down to it, very personal. It's about stories. It's about sort of human interaction. And being able to capture that in a narrative or in a story becomes an important part of being able to describe the human condition and to being able to describe really the experience that the patient is having, both in terms of their disease or in terms of their illness, as well as in terms of their interaction with the healthcare system. When you pair that with some of these structured things that allow us to do calculations and measurements and things like that, that allows us to have both the narrative and a way of taking that narrative, measuring it, and then working to improve it. So I think we have to find a way that both of those can coexist. And I think it will be important for both providers and patients, and really for the healthcare system at large, to be able to have that kind of partnership, if you will, or relationship, so that you have both structured and unstructured data to help support patient care.